Good afternoon. My name is Vanessa Rodriguez. I'm an associate professor at the Geriatrics and Palliative Medicine Department at Mount Sinai Hospital. And today I'm going to spend some time talking about geriatric assessment tools. To start, I have no financial disclosures. To review some of the objectives for this talk, what I hope that our audience will be able to get from this talk is that at the end, they'll be able to articulate what geriatric assessment is, particularly think about it from different lenses and how can this be helpful, how this is important for the care that we do for older patients. Explain the rationale for the utilization of assessment tools in geriatrics, discuss the strength and limitations of those assessment tools, and apply the use of the assessment tools in clinical practice. So to start with, the principles of geriatric assessment, the idea is to really get an overall holistic view of a patient, not just clinical health, but also other domains, mental, social, all the things that are very important when we care of a person. I think also very important that to emphasize that this approach, you have to keep a multidisciplinary lens. It really is geared to the wellness of the patient and keeping their independence when that is possible. And I think it's very important to think that the priority should be what is important for the patients, and really aiming to the quality of life. To do this, you may also have to incorporate in this assessment those other players that are in the care, like caregiver, whether they're family, whoever is part of their care, is important to be part of this assessment. We like to use this framework. I'm sure many of you are familiar with Dr. Dinetti's 5 Minutes of Geriatrics. This has been in the forefront of the framework that we use when we're thinking about how do we articulate what geriatricians do. So when we're doing a geriatric assessment, what we hope is that you're going to think about those very important core domains in terms of how can we be of value. So for example, thinking about mind, right? Thinking about the evaluation of not just this dementia, but also depression or any sort of conditions related to mental health, delirium, and so forth. Of course, mobility is really important. So that for emphasizing, reducing risk for injuries in regards to falls, impaired gait and balance and things like that. Medication is really important, thinking about polypharmacy or deprescribing in a safe way, and just kind of preventing adverse medication effects on medication burden as well. Multi-complexity, I think this speaks for itself, but just kind of thinking about all the different things that come and sometimes that patients have to live with. And so thinking about all the elements, not just like the medical, like clinical things, but just also psychosocial as well. And then the most important of the M's, the what matter most. None of this work will be relevant if we don't really emphasize on meaningful health outcomes and in terms of focusing on the goals and care preference of our patients. These are the different domains, and throughout my presentation, I'm gonna sort of cover these elements and particularly talking about different tools that we can think of using. The first important thing is I think it's very overwhelming when we're thinking of covering all the different things that we can, unpack on a visit. Many times we see a patient and we don't even know where to start. And so one approach is to do a rapid screening. And what does that mean is to do quick sort of assessment on most of the domains, if not on all, and sort of thinking about which ones are really positive to say. So for example, if you're meeting a patient for the first time, it's really hard to tackle everything. A comprehensive geriatric assessment is really more of a longitudinal assessment unless, a patient is in the hospital, you really have to prioritize what is the main driver of what brought the patient to the hospital. But in a clinic or in an outpatient setting, or maybe a person in a long-term care facility, this could be done longitudinally. So you may decide to tackle one now, and then in another visit, another one, and so forth. But really prioritizing which ones are more active. So for example, focusing like functional, you can ask, or even your interprofessional team can get involved, right? So let's say your medical assistant can come and ask the patients about their mobility. Have they fallen over the last year? And this could be communicated to the provider. So this could be a multi-team approach. If you decide to tackle, cognition, maybe doing a quick mini cog, we'll talk about that. Functional, I'm talking about the activities of daily living and targeting just a couple of questions about their day-to-day, about their medications, how do they get groceries, and so forth. And the same thing with all the other domains that I'm listing here. So you can quickly do a quick assessment and just ask a few questions, like vision. Have you had any new changes? Like, have you continued to be able to read? Is it a vision limitation, and so forth? So doing a rapid screening can unfold how to then more effectively do the comprehensive geriatric assessment. So we're going to move on to start with the function. I think many providers are familiar. I think not even providers, just, anybody in the healthcare is very familiar with the activities of daily living. It's so important in the evaluation of our patients. And there's two very famous questionnaires that we often use. And so we have the ADLs, indices by Cass and Bardo, and then we have the Lawton Instrumental Activities of Daily Living Scale. I'm also incorporating the direct observation, which is actually having patients do specific mobility exercises so that we can assess for fall risk and so forth. I will tackle the direct observation a little bit further, but now I'm going to focus on the first two. And so the activities of daily living, so this is very important, right? Because this is how a person can really remain independent in the community. It doesn't mean that if a person has an impairment, they can, but we would, knowing what the patient needs and what the limitations are, then you can provide access to the appropriate care. So what are the basics? Bathing, dressing, toileting, transferring, continence, and feeding. And in the index of independence of activities of daily living, the CATS index, it basically sort of asks this, and what is the level of independence, whether you are fully independent or if you need some assistance or if you need complete assistance. So that gives you a good overview of a person's ability to do basic activities. And so the bar thorough, it sort of covers this similar domains, and similarly, it's with the goals of understanding the most basic needs a person has on a day-to-day. The activities of daily living are very useful when we're talking about comprehensive geriatric assessment in terms of function. So they really use a very common language, so patients can relate to it very quickly. It really sensitive to pick up changes in declining health status. And it really, can pick up on specific changes that will tell you how a person is doing or predict how a person can do long-term, depending on what other medical issues are going on actively in their life. So for example, there is evidence and research that has proved that it could be a good prognostic factor for 1-year mortality following hospital admission. What that means is that if a person becomes, after hospitalization, more dependent on the basic activities of daily living, it can really affect the prognosis of a person. And so knowing that information offhand is really important, knowing what the baseline was and what the new baseline is. It can really be a strong predictor for length of stay, mortality, and nursing home placement. And even more than the diagnosis of admission. So if a person comes in with exacerbation of heart failure, but they really have a poor functional status in terms of their basics or instrumental, it can predict that they might not do as well after the hospitalization, and they might need, additional layers of care. So it's very important. It really can help predict even better than other factors, the prognosis of a patient. And then we have the instrumentals. The instrumentals are really these other things that are important on a day-to-day. So like preparing meals, do housework, use a telephone. Particularly very important that are assessed by the Lawton Instrumental Activities of Daily Living scale is how do they take their medications. That's really, really important because we prescribe, many of our patients take so many medications. So really not only when we ask, do you take medications? What do you take? We really have to understand, are they able to take them independently? Do they get any help? What's the help like? And so forth. And the same using transportation means, do they need assistance or not? And so in the same way, the instrumentals of activities of daily living also similarly can help in sort of anticipating what could happen to a person in response perhaps to, to treatment, for example. Persons that are really dependent on instrumentals activities of daily living, research says that they could really have poor survivals. For example, there is research done in lung cancer patients that have shown this. Similarly, it can actually predict patients' increased rate of postoperative complications. The more dependent they are, the more likely that they could have postoperative complications. And then moving along to mobility. So the CDC created this amazing set of a toolkit that it's available for providers, and it really has just being at the forefront of evaluating patients that are in the community, adults 65 years and older that are high risk for falls, or patients that have fallen. And really what they have done is kind of categorize. So it's basically have created a toolkit, which starts with helping providers in the community to learn how to prevent, how to assess, and how to intervene. Basically, if you identify a person that is at risk or has fallen, what interventions using evidence-based are available to keep patients safe and perhaps predict falls and help them in the community. And within this assessment, so they recommend tools that are very commonly known in geriatrics, one of them being the time to up and go, the 4-stage balance test, and the 30-second chair stand. And we're going to cover them individually. They're evidence-based and they're very quick, easy to do on a visit. They're not necessarily very time-consuming. You can pick one of them. All three can assess for risk of fall, so it's really helpful to take a little bit of time for those patients that need it. So for example, for the time up and go test, it's a very quick, tool that you can use in a visit. And it basically involves having a person rise from a standard armless chair. And then if they use some form of device, whether it's a walker, a cane, whatever device they use, they will use it during this exercise. And what they do is they'll walk about 10 feet. They should be wearing comfortable shoes and go at the fastest pace that is safe enough for them to use. They're going to turn back, walk down, and sit. And so at this point, what you're looking is, their pace, their balance, their gait, if they're helping themselves to, while they're walking, if they're helping themselves by using the wall or if they have a proper arm swing and so forth. And this is how it looks in practice. Again, it's very easy to do and it requires very little equipment. And basically, a person that takes over 12 seconds or longer, it can predict that about, by 90% accuracy, that it has a sensitivity about 88% and specificity of 94%, and predicts that those patients have a really, really high risk for falls if it takes them over 12 seconds. Older adults who take longer than 12 seconds to complete the test definitely may have a high risk for fall. So strength of this test, it takes less than 1 minute to complete. It requires only a chair and a watch, like I said, and it has a good inter-rater reliability. If it has over 12 seconds, we know it's increased risk for fall, but if it's more than 10 seconds, it really can predict that the person might have a risk for an ADL impairment. And if it's over 30 seconds, it really can predict that the person will have some ADL dependency. So it really can help into really assessing a patient in a very accurate way. Then we have the 4-stage balance test, which assess for static balance. You only need a stopwatch, very easy to do, very quick. And all you have to attempt to do is have the person in front of you keep these positions for 10 seconds each. And if the person can only do the first one and they already, they're swiveling or they're about to lose their gait, you stop. And if they stop just on the very first one, definitely you can see that the person will have a very high risk for falls, but you really try to bring them all the way to the end without any assistance. So they'll keep this position every 10 seconds. And so, like I mentioned, not being able to hold in the tandem stance at any of this for 10 seconds is definitely an indication for increased risk for fall. Then we have the 30-second chair stand. And this one is, in addition to risk for falls, it also helps to assess the proximal muscle strength and endurance. Again, another very quick evaluation. You can do it in your outpatient setting or in other settings. And you need an armless chair with a straight back and also a stopwatch. But very easily, you have the person sit in the middle of the chair. They place each hand on the opposite shoulder, sort of like if they're hugging themselves. They place their feet flat on the floor, and then they're supposed to keep their back straight and keep your arms against your chest. And so when you tell the person go, they will, as much as they can, stand all the way up and have them sit them back down. Not halfway, they have to be able to do it all the way up. And this is how in practice it would look. And one important piece of this is that on these tests, they do allow for, so sort of like predicting how much do you expect by age group a person to do, and also by gender. So it's good to know that if you have for example, a woman that is between 85 and 89 years old, the score or the expected average would be perhaps different than a person that is 65 and 69. So it's good to note that because if a person does 8, that might be appropriate for a woman in her 80s, whereas the expectation might be around 11 for a person 65 and 69. It's good to know that difference is same for a man. This is a list of other available tests, but like I said, these tests are part of a toolkit that is being evidence-based tested, and it's really easy to do in practice in the clinics, and it needs very little equipment. Now moving on to another element that I personally think is very important, that when we're thinking about mobility and function, driving assessment is actually that we should be thinking of in the care of older patients. Some patients really rely on this as a mode of transportation and really of caring for themselves. But for example, there are driving behaviors that can change over time. And so if somebody is showing some of these behaviors, so for example, failing to stop at signs or failing to yield to the ride, driving too fast or too slow, getting lost frequently, difficulty judging distance, this is a time where you should actually sort of do a better evaluation, because there might be a lot of other things that might be happening that will be serious. And this is a safety also, not just for the patient, but for other pedestrians or other drivers. So what can you do in the evaluation, in the visit? You can do some of the things that you're already doing, incorporate them as part of your thinking when you're thinking about driving. So you would review the medication list, right? Our patients are, they take a lot of things, so antidepressants. antipsychotics or antihypertensive or antihistamines. You want to do a good review of the medications that may impair their ability to drive, but also if they drink, right? Some other things that are not necessarily medication, but that could also impair the ability to drive safely, or if they use drugs and so forth. Thinking about the status of medical conditions, whether they're chronic and new. So, for example, visual impairments or cognitive impairment and so forth. And some people might have new acute problems, right? So, heart issues or whatever it is, or neurological things you might want to pay attention to. Also ask about the confidence in driving. Some patients might need to be asked. They might not be forthcoming about it, but it's important. You have to ask about accidents, tickets, getting lost, particularly if you're concerned about it. And if you don't know, and if there's a family member, they might bring some collateral information. And also evaluate for sensory impairment, visual, auditory, and so forth, which are very important that to be intact when a person is driving. And absolutely, when in doubt, take the time to screen for dementia, particularly when they're getting lost and they're having new scratches on the car and they don't really have a good explanation. It might be a good thing to think about. And the way to start this conversation is really framing the conversation around safety, right? Just talking like this would be like about any other medical condition or any other way part of your assessments, whether it's for mobility function. You can even talk about keeping independence in a safe way. So you can frame it along those lines. And having a one-on-one discussion is possible. You can start in private, so the person doesn't feel, that you're touching on very sensitive topics in front of some other people before you discuss this with them directly. Talk about alternatives to continue transportation. If it's not going to involve driving anymore, try to start bringing those up ahead of time so they start thinking about it to foster independence, and absolutely show support. When appropriate, make sure that you show support because this can be very sensitive for many patients. So in terms of next steps driving, suggest alternative modes of transportation. For example, whether if they live in a place, they need, they might need a shuttle to bring them over to their appointments, whether it is to take a bus, whether it is to take a taxi, whatever it is, somebody else to take them, to think about those options. If you have low concerns for serious issues, such like dementia, you may suggest adjustments in driving and behaviors. For example, not driving in the nighttime, not driving during the rain or peak hours. So making adjustments to the way they're driving to maximize safety. You may refer them for a formal driving evaluation by an occupational therapy, again, with the caveat that Medicare, Medicaid, and other insurances, the coverage might vary. And you may also check with the state licensing agency for a free older driver reexamination. I want to say, though, it's important that this conversation happens, particularly the state takes very seriously that if a provider has a high concern, if they report a driver, and they're asked to come for a driver examination, if the person were not to show, they can revoke their license. So this really has to be sort of like a conversation in anticipation for the patient and really frame it to the patient in terms of safety. Now, moving along to cognition. So in terms of mind, so things that are important to pay attention to. So red flags to consider an evaluation. So if somebody is forgetting things, right? Somebody that always is being on top of everything, particularly if there are people that, for example, somebody that was an accountant and all of a sudden is missing payments or having difficulty managing bills, or somebody that was so on top of their medications and now you hear they're forgetting medications or missing doses or confusing them and so forth, or even new issues with driving like we just referred to. Similarly, if there are changes after new medications, you need to keep making sure that the patients are not having any adverse effects. So it's good to keep an eye on that. If there's any functional changes, so if a person all of a sudden is requiring help or assistance with those basic activities of daily living or instrumental, like we mentioned earlier in our talk. If it's in bereavement, somebody just lost somebody or sort of a trauma event in their life, this could affect their cognition. They might not be able to think clearly, and you may have to pay attention to that and may impair their cognition. Somebody's presenting with atypical depressive symptoms, so like anhedonia or insomnia or inattention so far. It's good to know if there is something else that is unfolding and if there's new concerns for new medical issues. And so in terms of cognitive domains, so there's different tools that we can use. A very common one that is being in practice for a long time, it's been the mini mental state examination. We assess for 7 cognitive domains, and so related to orientation, to time, to place, repetition of words, attentions, calculations, recall of words, language, and visual construction. And you get a max points of 30. And with a person scores below 23, you may suspect a person may have dementia. This might be a reasonable test, particularly for persons that don't have a high level of education. It might be a good test to pick up. And this could be a follow-up as more shorter versions, which I'll talk about in a moment. And then there's the short portable mental status questionnaire. Not, it depends on the place of practice. Some places might favor mini mental, some will prefer the short portable mental status. I often use more of the MOCA, and I'll talk about it soon. But it's really good that you are familiar with some of them so that you can use and do them properly when you're assessing a patient. This one is a 10-item questionnaire, and the more higher the score, the more severe the problem. This clock drawing test, which is another option, is a very, very simple one. It really takes very little. Sometimes you don't even have to, you don't have a time limit here because it's such a simple test. And the idea is really kind of to see a little bit of cognitive abilities, sort of like executive functions. It's really more like it could be one of those like rapid screening tools. And it's an excellent in acceptability by subjects. And the way you would score is very simple. You could even have there's different variations of it. Some people have the circle ready for the person, but you may also have the person draw the circle for you. But regardless of that, really what you're looking for is that all the numbers are there, that they're on the right order, and that the hands look in the pointing to the time that you have indicated to the patient. And there's different ways to score. Some people might have a person do a couple of them, but there is evidence that suggests that just doing it one time and just saying correct, you give 1 point, and 0 to incorrect. It's as predictive of having some potential need for screening further for cognitive impairment. It's enough, so you could do that. And then we have another similar one, which is mini-cog. In the mini-cog, it incorporates a clock drawing test, but this one also incorporates a recall element. So you have a person, you say 3 items, you give them, they'll repeat them back to you, and you'll divert. And the diversion happens with the clock drawing test, which we just covered. It's very simple, usually does take a few minutes, 3 minutes or so. And when you're done with the clock drawing test, and you go back and ask for those 3 questions. The way you would score this is if a person has 3 items that they're not able to recall any of the 3 items, then you would do a more deep screening test because there will be a risk for neurocognitive impairment. In the middle, if somebody can only record 1 to 2, but they have a normal clock, then less likely to be having neurocognitive impairment. But if the clock is abnormal, then it suggests that you should do further screening and testing. And then if the person recalls all 3 words, then, less concern for neurocognitive impairment. I would say, though, in practice, if there is some level of suspicion, somebody is like very highly educated, and you could still proceed with a much longer test. But the mini-cog has a good good sensitivity and specificity compared to other longer tests. So like the mini mental, sensitivity of 76 versus 79, and specificity is almost the same. And then to compare to neuropsychological tests, which are those long 2 hours battery tests that sometimes we refer patients to, similar sensitivity and similar specificity. And it's good because in terms of ethno-linguistically diverse population, Mini-COG is a good tool to use. Then we have Montreal Cognitive Assessment. This initially was designed for mild cognitive impairment. It takes, I would say, about 10 minutes, a bit more sometimes. And you really have to make sure that because you're going to be longer with the patient, that the room and the setting is appropriate without interruptions, because it takes a little longer. And so this one is tests for short-term memory, visual spatial, executive function, attention, concentration. And it says, the max score that you can get is 30 points on this test. And so the cutoff is 26. And so if a person, scores below 26, it would be considered abnormal. It has a sensitivity for mild cognitive impairment of 90% and 100% suggested for Alzheimer's. I think the best function for the MoCA is that it's very good specifically for this mild cognitive impairment element. So there is some research that has recommended that if a person has a cognitive complaint with functional impairment, you may use the Mini-Mental. It tends to be simpler, but if it's normal, then you can use the MoCA to further assess. But if a person has a cognitive complaint without functional impairment, then the MoCA might help more to really tease out those persons that have mild cognitive impairment. There is another screening tool called Rowland Universal Dementia Assessment, known as RUDAS. This one is what has a very what makes it more attractive to some providers is that it reduces the impact of language and cultural differences. So he's being tested and reproduced in different languages. And the score of 22 or less it would be the cutoff to require for the cognitive evaluation. It has a sensitivity of 92% and specificity of 75. But there are some research suggesting that it still needs some adjustment for level of education, so to help this tool to increase the diagnostic accuracy. And then there's this other tool called the AD8 dementia screening tool, which could be also seen as a small, like a short survey for patients. They can actually complete it themselves, could be on that rapid screening option. And it's a direct patient questionnaire. It's brief, about 3 minutes. And combined even with the Mini-COG, there's research saying that it can help detect early cognitive impairment. The value is because it's a direct patient questionnaire. It doesn't require formal training like other tools like the MoCA, for example, which would require at least some training via webinars. But this could be a really good tool to kind of assess patients pretty quickly. A score of 2 or more would suggest some cognitive impairment and will require further evaluation. And then, of course, we can't talk about mind without thinking about, delirium. This is a very known tool, particularly in the ICU setting. The CAM, the Confusion Assessment Method, which was designed initially for non-psychiatrists, is really a tool where you assess for delirium. And so how would you use it? It's very short, it takes less than 5 minutes. And what you would look for is if a person has an acute onset, so a changing mental status that was pretty quickly, and has a fluctuating, so those that are wax and waning, and whether they have inattention. They have to have that inattention, so you're talking and they seem sort of distracted, plus either a disorganized thinking or an altered level of conscious. So they have to have acute onset, fluctuating course, and inattention, plus one of these other 2 elements at the bottom. And then moving on to affective, to the mood, so that 5M, the mood. So 2 very commonly used tools are the Geriatric Depression Scale and the Patient Health Questionnaire. And there's other tools, but in practice, in the outpatient setting, these are known to be used very frequently. And the GDS has like different versions of it, the 30, the 15, and the 5-item tools. And then the patient health questionnaires has a screening tool of 2 questions, and then has a 9 question, which will follow a positive PHQ-2. For the geriatric depression scale, so for the 15 item, so if you score over 5 points, it's suggestive of depression. And then if you score above 10 points, it's almost indicative of depression. So this is a geriatric depression scale. This is the 5-item one, which basically takes some of those questions that were tested in studies to see if they were on themselves really valid to use as one sole tool. And it has performed really well. So if you score 0 or 1 points, less likely to be depressed or not considered depressed. But if you score more than 2 points, then the person is considered to have depression. And when they compare both, one of the advantages is that the 5-item only takes about a minute, whereas the 15-item takes 3 minutes. And I think time is priceless in clinical practice. So if you see how they both perform, both have the 5-item has a sensitivity of 97% compared to the sensitivity of 94 in the 15-item, and similar specificity in both. And then accuracy a little better in terms of the 5-item. So really, when time is precious, you might just be able to use the 5-item depression scale. For the patient health questionnaire, so it's a brief tool. You may have to explain clearly to the patients how to answer, but once they start understanding the instructions, they're able to get through it. It's a brief self-report tool, and it can be given to patients when they're, if a person scores positive, let's say a medical assistant asks the first 2 questions and they're positive, whether they're having little interest or pleasure or feeling down, depressed, or hopeless. If they say yes to any of those, then it activates for you it tells you that you have to screen further. So you will use the 9 questions tool, and it could be given to the person. They can start completing on the waiting area or waiting for you in the room. And it incorporates the DSM-V criteria for depression. It has a sensitivity of 80%, specificity of 88 for major depression. And one of the very important aspect is that it screens for the presence and duration of suicide ideation, which is very important. And so it's something that some other tools do not have this advantage. But again, the patient health questionnaire it kind of screens for those atypical symptoms of depression in older patients. This is an idea of how you would score for the severity, depending on the score a patient may have, up to 27 points. So you can see here the degrees, how they will be scored from 1 to 4 minimal, 20 to 27 will be severe. So in major depression, if it's over 15 points, and you would consider major depression, but less likely to be major depressive with score less than 10. And this is how you can think about planning and monitoring the patient. I think one of the values is that it's a good tool. So if you start therapy, you can actually kind of longitudinally use this tool to see if a person is responding to therapy. It has been in research shown that it is helpful for this purpose. And so here you can see, that it also accounts for if the person has had a significant score. It also adds a question at the bottom where it says, if you check off any problem in this questionnaire so far, how difficult this problem made it for you to do your work. So it also accounts for asking somewhat what I would categorize a level of disability, depending on the symptoms. It's important that you also sort of rule out if there is any bereavement happening, or manic episodes, or physical disorder, or medication problems, anything else that may be impacting the score. It's important to take that into account. Very briefly on vision. So, visual impairment is not uncommon in older adults. And so there's 4 major diseases that are in high prevalence with age, such as cataract, macular degeneration, diabetic retinopathy, and glaucoma. And it's one of the most common sensory deficits in the older population. So we have to at least ask. You may not need to do the full evaluation. Most patients are referred to an ophthalmologist or optometrist, depending on what the concern is, or if they have a previous condition. But it's important to be aware of. And some providers are able to do a quick, Snellen chart, remembering that 20/20 is what we would aim for. But you would have the person read, with one eye first, then with the other. You would have them read the line that they would get the closest to be perfect. So if they miss one or two elements, it's okay to say that they can read that one line, but if they have more errors, then you would have to go through the next line. So this is a very quick tool. In practice, it's also used in younger patients as well. And this is in the Amsler grid, which is a basic field test that you can use for central vision and macular degeneration. But again, a lot of these patients have, more serious conditions, and they might warrant at least, you may want to just connect them with an ophthalmologist properly. Hearing, it's very important. There is a big prevalence of sensory neural hearing loss, and there is very quick tests that you can do in practice. One of them be the whispered voice test, which basically involves standing behind a patient's field of vision. You close, they include the ear canal, the one that is not being tested, and you basically ask the patient to repeat a set of 3 random numbers, and you're sort of about presented between 6 inches or 2 feet from the ear. Before you do that, you exhale completely prior to the testing, and you whisper very, very, very gently those combinations of numbers. You can do also letters as well, but the idea is that the passing score is given if the patient can repeat all 3 numbers correctly at each level of loudness or achieve greater than 50% success over 3 successive triple sets. And again, whisper test takes about 1 minute, and it has good sensitivity and specificity compared to an audioscope, and does much better compared to a hearing handicap. So it's a really good test, very simple to do in the outpatient setting. And this is just to show you some of the devices that are available to help patients that are navigating sensory neural hearing loss or any hearing impairment. There's different equipment that you can use for the persons to use in practice. I know that some hospital facilities and outpatient facilities have pocket talkers, which could be great for, compensating for noise, and so helping patients communicate better, but also, other elements for safety. So like bed shakers or light alarms and things like that are really helpful for persons, particularly if they live alone. In terms of medications, so as you may know, the American Geriatric Societies and Choosing Wisely campaign have been very clear that don't prescribe a medication without conducting a drug regimen review, because sometimes we might end up prescribing medications to minimize or mitigate the side effects of another medication. But what they say is the most common definition of what many patients go through, which is polypharmacy, is taking 5 or more prescribed medications daily. And so it's really good to take a look every visit. I do that every visit because medications change all the time. And also patients have access to over-the-counter medications now more than ever. Or they have access to medications from friends or family members. It's good to always, always ask. And it's good to think about medication reconciliation and safe prescribing. So there is the Beers criteria, which is a list of potentially inappropriate medications used in older adults. Of course, the list doesn't take into account all medications, but there are medications that might not be as safe for older adults. And these are some of the medications that are considered. Of course, it's important to understand the context of what they're taking it, and not just to take the approach of stopping quickly. So one tool that can be useful to thinking about this is stop and start. So red is, have 3 color categories. So medications to consider stopping, medications consider starting, and the blue is considering the NICE guidelines of how to navigate complicated medication, the prescribing. So it's good to have an idea of, what medications can be unsafe, but also very important is understanding why patients are taking it. There are many medication management tools. So I'm putting here for your review some, the pill box is a very common one and it's relatively cheap. We have blister packs, so like a pre-packaged system. Some pharmacies have them available, not all pharmacies, but it's becoming more popular and more accessible. Planning ahead, so like having a calendar or setting an automatic refill, or on the phone also there's ways to kind of put alarms, making a list, whatever it is best. Some patients need to have some medications at the bedside because it's the first one, like the thyroid medication, the osteoporosis medication, or whatever it is, they need to have a proton pump inhibitor, so that they take that one and go by their day and they're able to take it effectively. So there's many ways to do medication management, just have to think which one is appropriate for your patient. Then social, what matters most. So again, social is one of the biggest domains when taking care of older patients, and social determinants of health really account for 75% of the factors that influence health. So really understanding the context, that not just the interactions, that there's so much complexity among the interactions that patients have to navigate, not just from the healthcare, but also economic, cultural, social, physical environment, individual behaviors. So really understanding the social determinants of health for your patients and documenting them can really help patients navigate their own health. And so that is very important, and understanding really what matters most for the patients along the way. So well, the USPSTF recommends screening for some social determinants of health, and the list includes elder abuse. Is not often actually considered in practice. I think the caveat is because, or the difficulty is, there's no specific tool that has been identified for older patients. But there are some studies that recommend some options, and I'm listing some here. So things to navigate and sort of read through and see which one will apply for your own population. But it's just understanding all backgrounds, not just going beyond just the very simple medical history and the family history and the surgical that we're trained in medical school. Just understanding how do you have access to food, what is your financial situation, so you have insurance, what type of insurance, do you have access to food, how do you get there, how much, all that sort of things are very important. And then in what matters most of good quality of life in advanced care planning is at the forefront of caring for older patients. So keep in mind, very important, like your biases as you're thinking about this element. But it's important to determine the preference of a patient, even if a person has cognitive impairment or a disability of some form or limited literacy. Understanding the way to get the information from the patient and incorporating them on these conversations is really, really important. And there are some validated tools. There is the SF36 health that is really focused on health-related quality of life. It's one of those that has been studied and validated to understand quality of life aspects in patients, and it assesses the physical, mental, and social aspects of it. And there's other that I'm listing here. Mostly have been used in research, but some are perhaps more incorporated slowly into clinical practice. So just a few to kind of think about as you're assessing for quality of life. And then we can't talk about all of this if we don't consider caregiver burden. It's part of the comprehensive evaluation. If a caregiver is burned out, it's really important to assess that as well, because it really will be difficult to care for an older patient if the person that is helping provide the care is not doing well. So caregiver burden should be evaluated, particularly if a person has a diagnosis of neurocognitive impairment, which really brings a lot of caregiver burden. So there is a known tool, the SARI burden interview, and again, it has different versions of it, and it's become shorter over time. And there is a 3-item screening scale that can be considered. The steroid has been used a lot in research, but it's becoming a little bit more useful with the 3-item screening scale in clinical practice. And just asking very simple questions. Are you afraid what the future holds? For your relative, is your health has suffered because of your involvements with your relative, or have you lost control of your life since your relative illness? Or yes or no. And then it's important to kind of assess those to further intervene. And just a final key, I think after all of this that has been covered in this presentation is understanding that there's several tools and considerations to comprehensively evaluate an older adult. And using the 5Ms framework can guide that evaluation, as that's the framework we should use when thinking about older patients and what our specialty brings to it. So remembering to use the medical and also the social determinants of health, a really holistic view, and that you don't have to do it on a first visit or in a first encounter, particularly if you're a provider at a long-term care facility or an outpatient setting, or if you're home-based primary care, you can do this longitudinally, whereas another will be more limited, but you have ways to do rapid screening and more comprehensive testing later. And that's it for the presentation. I'm gonna, just as some practice, I'm gonna present 2 questions. And so the first question is a case. So for my case, I have Mrs. GC, who is an 83-year-old woman, has a past medical history of hypertension, prediabetes, and knee osteoarthritis, presenting to the primary care clinic with her daughter, who is concerned about her mother's increasing forgetfulness, particularly misplacing objects and some difficulty managing medications. Additionally, she's concerned about her balance, which has led to several near falls. And Mrs. GC lives alone with her, and her daughter, who lives out of state, worries about her safety. Similar encounter we've had in primary practice. And so the primary care decides to perform a comprehensive geriatric assessment to address her cognition and fall risk concerns. So which combination of assessment tools would be most appropriate for evaluating Mrs. C cognitive function and fall risk? And the answer to this question, yes, would be letter A, the Montreal Cognitive Assessment and the Time Up and Go test. And the reason this is the answer is because not only because the MoCA is a widely validated tool for assessing cognitive function, but it's the combination attached with the Time Up and Go, which is a test that is well regarded for the, like I mentioned before, it's on the steady toolkit, but it's a really good tool to assess for risk of falls by measuring the time it takes for a patient to rise from a chair, walk a short distance, and returning to the chair. So it's a good combination. Why the other answers are not the right answer? Well, the MMSE is a tool to evaluate cognition, but the patient health questionnaire is really more for depression, the same way geriatric depression scale is. And then the remaining tools can be helpful in comprehensive geriatric assessment, but they do not directly address the concerns that are important for the patient and the daughter. Question number 2, an assessment of instrumental activities of daily living typically includes which of the following? And the answer is B. Decline among all, and this is, again, for those that remember, ability to take medications, and the answer is B, because it's one of the options in the activities of daily living. And decline among older adults is commonly assessed using one of this screens with the basic activities of daily living and the instrumental, and this being part of those activities. So the basics, as a reminder: bathing, eating, transferring, dressing, and toileting. And then for the instrumentals, remembering that it's like the more day-to-day task. So preparing a meal, finances, housekeeping, medication management, and so forth. And they require a little greater complexity. And with that said, thank you very much. This is my contact information. And if you have any questions, please feel free to reach out. Thank you.